Welcome to Monetizing Innovation. I'm John Holcomb. Innovation isn't just the big idea on the whiteboard, it's the hard decisions, the missed signals, and the leaders who keep moving forward anyway. This show dives into the real stories behind breakthroughs in life sciences, healthcare, and tech, how ideas become results, how teams align under pressure, and how strategy turns into execution. If you're building something bold or looking for clarity to lead with confidence, you're in the right place. Press play and let's turn innovation into impact. Well, welcome everybody. I have to admit, we have a very special guest today. Very pleased to introduce Jonathan Meek. He is the managing director at Precision Healthcare Strategies, LLC, where he advises healthcare organizations on precision medicine, commercialization, AI strategy integration, and innovation that bridges clinical science and real world impact. With deep experience guiding precision medicine initiatives and helping clients leverage data driven solutions in healthcare, Jonathan brings a forward thinking perspective on how precision medicine and strategy intersect to shape patient outcomes and business success. Tune in as we explore his insights on AI, healthcare transformation, and strategic leadership in complex healthcare ecosystems. Jonathan, welcome. We really appreciate you being here today.
Thanks, John. This is an exciting topic, and I'm looking forward to contributing to this topic today.
Excellent. Well, Jonathan, my introduction probably doesn't even do justice to all the work that you've done. One of the things that might be really helpful for the audience is if we briefly even frame out what is precision medicine and what does that mean to the broader population?
And it's a great question because I was thinking that for the discussion today, a little bit of framing because for not everyone really understands what precision medicine means. But essentially, precision medicine is about tailoring the delivery of care to the specific biology, the specific patient needs. If you think about in the past, a lot of the medical and surgical pharmacological approaches haven't had the level of information, the data allowing it to tailor specific to the needs of the patient. So, although most people in precision medicine may think about oncology, it's moving into cardiology, it's moving into neurology and immunology and metabolics as well. So it's an evolving landscape.
No, and I think that's really helpful. It holds such enormous potential, but so far, I think adoption has been a bit uneven. What are some of the biggest barriers you see, and how should leaders overcome them?
Look, I think this part of the sort of building a foundation. The first question is, well, what is innovation and how does it apply to precision medicine? And really I mean, there's 1,000 different ways that people want to approach the innovation definition. But for me, it's around creating value by introducing something to improve the status quo, whatever that is.
Mhm.
Now, when it comes to precision medicine, you're absolutely right. The adoption has been uneven, but I think that unpacking the drivers behind that is useful in terms of applying our focus to how do you solve for it? How do you create great execution? And one of the things that precision medicine sets out to do is to change the workflow. The workflow meaning, can I improve how I identify the right patient? And we can get into that, but essentially, it's evolving to, can I be more proactive in finding that patient? Can I find them with a greater level of accuracy? But the next piece is, what are the diagnostics? If precision medicine is tailoring the therapy to that patient, how do we know how to tailor? Well, the diagnostic program, and you may think of a diagnostic test, but in the world of AI, many things are being looked at now that are looking at all of the biomarkers that might actually help tailor that therapy. The third piece is planning the care. And, I think in the pharmacologic space, just as an example, because it's not limited to that, you might have the first line of therapy, then a second line of therapy, and the third line of therapy. There needs to be a workflow, a clinical rationale about what I do first. The fourth piece is to deliver that care. And I think one of the things that people forget about with precision medicine, and like with anything, is that sometimes the delivery of that care may need some course correction, which brings on the last piece, which kind of creates a cycle as well, but it's monitoring that patient. If you're in the oncologic space, then I guess that what you're wanting to do is say, have I got that cancer under control? And when will I know if it comes back again in a way that I can be proactive to deliver that? Back to your question around the adoption and it being uneven. The thing that I want our audience to understand when it comes to innovation, sometimes solving the problem or identifying the problem to solve is one thing, but understanding the problems behind the problems, and I'll refer to this a couple of times today, is going to be maybe even more important. Let me give you an example. Precision Medicine Coalition did a study of 1,000 non-small cell lung cancer patients back in 2022-ish. And what they found of the 1,000 patients, 36% of them ended up getting the precision medicines that they should have got. Now, if you think of that, those five buckets: identify, diagnose, plan, treat, follow up. The problem behind the problem is that if you're an oncologist, being able to adopt those new therapies and to be able to do it confidently, so have what we used to call an intention to treat, means that I have confidence to prescribe it and to deliver it to you, John. But many of the oncologists would say, look, Jonathan, it's much better for me to prescribe maybe an older therapy with great confidence than a newer therapy that I kind of don't know what's going to go on. And so I think that the critical piece here is start with the end in mind, be able to have a clear clinical aim, but to bridge the what we call the last mile, to give people the confidence that I will want to treat with that therapy and why, to be able to measure proactively, is it going to be successful or do I need to course correct? And make sure that they know what diagnostic data needs to be put forward to be able to make that decision. So overcoming them is really about that understanding the problem behind the problem and focusing in on that.
I think that is, yeah, so insightful, especially that perspective. And, one of the questions that came to mind as you were explaining that too, especially in the last mile aspect of it, is how do the roles of the hospitals and the insurance companies come into play? Do they, because I know sometimes, right, there's a approach of, hey, we're going to try the lowest cost method first and things like that. Is that something that the data can help us get to that next level where it's like, hey, this is going to be the most effective treatment and move forward that way?
Love this question because so many times, and particularly in the world's healthcare economy where people are looking to save cost, the challenge is that healthcare cost measurement and in fact the workflows of execution are often siloed. And in my early career in the areas in the operating room where you would pick up a new technology that would save an enormous amount of hospital stay, then people in the wards would sit there and say, "Hey, I'm not being rewarded
Hmm.
because my patients are sitting there for 1 day rather than 5." And then the hospital CFO is saying, well, yes, the saving from the ward goes into the additional cost in the operating room. So what does that mean? And I think that if the question is, where is the future of healthcare? A lot of it is around the ability to very specifically build data that will enable you to understand and predict not only the clinical flow and the operational flow, but the economic flow. And if you think about if you get that right, and you think that, hey, if I can treat you before your disease is too advanced for you to get good clinical outcomes, if I can identify you and treat you very specifically, then it will actually help the insurance company. But most critically, often spoken about, poorly focused on, is and what benefit will it mean for that patient to be able to be treated early, more effectively, and what will it mean for their long-term quality of life? So that question around measurability, economics, clinical workflow is just such a fundamental piece of this.
No, I appreciate that perspective and understanding too, because I think it does help us understand, right, some of those barriers to innovation that we have to work through. And when you look at that for many of the health care organizations that are experimenting with AI, where are you seeing the real scalable value today? Because I think we're kind of in that transition, right, of getting to where the future state that you just explained and where we are today. So where are you seeing that really come to play?
I think that to me, the word scalability is an important piece. When we often talk about integrating agentic AI into hospital or healthcare provider, biopharma, for instance, into their workflows, you often get a look of panic. And a lot of it has to do with being able to focus in on, start with the end in mind, have goals, have measures, have workflows. But I think that when you have a look at the question around hype and scalability, the approach is, what do you want to achieve when it comes to innovation in this space? You could be saying, look, I'm going to use the same workflow, but I want to improve the fidelity of that workflow, make it more effective. You could say, I'm going to have the same problems, but I want to improve the approaches to solving those problems. Removing things that are low value add. How do you know that they're low value? How do you know that they're not just shifting the cost up or downstream? The third one is same execution, but better measurement. To say, are we doing steps A, B, C, and D in the right cadence? And how do we know that? And the last one, I think, and this is where I'm seeing a lot more coming up, is to say there's an old problem that has no solution because we didn't believe the solution was either viable or just able. Now we can have a look at this. And I think that the question is around who does well with the scalability piece of it. It's about it coming back to that old adage that's those people that start small, learn fast, grow quickly are those people that can course correct before it's too late, that can measure what is doing wrong, that maybe could be improved and make those changes. These are the people that go from having, a pilot mentality to sustainable impact.
No, I couldn't agree more with that. And that kind of leads perfectly into one of the insights that I would love to get your thoughts on too, is clearly that it takes a lot of leadership to lead through the complexity. And you've been driving a lot of this type of work through as a thought leader in this space. But where do you see healthcare innovation, in terms of leadership navigating between the regulation, data privacy, culture change? What are some of those behaviors and some of the key leadership challenges that you see ahead?
It's a great question, John, because over 30 years and 25 countries, one of the biggest frustrations that I've had has been calling out innovation and not executing to it. What does that mean? Well, you can look at innovation as being incremental. It's looking at the what and changing the what, tweaking something and knowing that that tweak may be incredibly appropriate, incredibly valuable because it doesn't need to be fundamentally changed. But often my frustration is innovation leaders talk as if they're transformational and deliver it as if they're on incremental. That's wrong. What is right? If it's incremental, but call it out because you're managing the expectation of the people whose world you're changing and knowing that giving them the level of comfort that you've understood what you're improving and why is critical. So we've talked about the tactical piece, which is sort of the what. Then there's the
Mhm.
substantial piece, which is the how. How are we doing this, and can we actually change it? But doing fundamentally larger pieces of change in the workflow or whatever that looks like in
Mhm.
execution. The last one is transformational. It's the why. Why are we doing it this way anyway? And can we actually change it? So we've gone from the what, the how, and the why. Curiously, my view is at the moment, as the world changes in healthcare, the why is going to be one of those things that, on one hand, is saying "Hey, it's a very large, high lift. But on the other hand, what it's saying is the world expects in healthcare now to improve patient care, be more proactive, but to do it in a way that mitigates waste and optimizes the delivery of that care in a way that's executed that uses resources more effectively. And so I think that when you come back to your question around what does innovation leaders look like, they are very clear about what they are trying to solve for. They are very specific about engaging with their target audience, their customers, and making sure there is alignment with that. But the last one, they're also very sharing those results and to be able to scale those results. Because without that, and there's so many examples of this,
Mhm.
when I was involved with the introduction of laparoscopic surgery, one of the things that you found is this was transformational innovation. Remember, I said problems about the problems, your problems behind the problems. Then going and having these surgeries without a large incision and turning it into, 4 or 5 band-aids was really attractive.
Uh,
And you would think to yourself, why wouldn't anyone jump into it? Well, the problem was that if you were the surgeon, the whole idea of operating on scary things like, arteries and organs without making a large incision so someone could quickly get there was terrifying. And so I think the innovation piece of that meant that those leaders who were executing were focused in on, for this ultimately to be successful, the patient, we need to understand what happens upstream of that. And, as you can see, it's now the gold standard in surgery around the world.
No, I think that's such a wonderful example, right? Because you can definitely relate to how less trauma it creates for the patient, how it's so much better. But the introduction, I can imagine, right? Because it's the lack of visibility, the lack of some of the understanding, right? When you look at some of that, it really makes me feel like we're in a bit of a renaissance period from a technology perspective. But I think what you really helped highlight is there's so many challenges of, okay, how do we create that big picture and go through, the what, the how, the why. And when you look at that, what do you think that the next 5 to 10 years truly looks like in terms of this shift towards precision medicine and the promises that it can bring? And how do you think that's going to impact leadership in the industry here?
Look, the next 5 to 10 years to me is fascinating. People talk about AI, and unfortunately, it seems like every sentence that's being used today, there's something attributed to AI. I'd like to think about it as advanced analytics, and AI is in multi forms, but essentially, it's saying that if you can have an outside in thinking, so if you can think as a leader, what is the target audience? What is the problem to solve? What is the customer that I need to be able to improve his or her life? How can I produce quality? Then that outside in thinking is going to be critical. But when it comes to the future, I like to use with everyone that I speak to this term imagine if to word to the audience, as you're looking to ideate innovation and how you want to deliver that, and you begin with the problem to solve and look at the problems behind the problems, including things like adjacent competition. Who would imagine that some of these organizations that went broke were taken out because someone came in from an entirely different place, like, surgery replaced by drug therapy. The surgeon wouldn't have thought that there was going to be a drug that would come through that would mean that they weren't doing these large surgeries anymore. But what it means is, as we're looking into the next 5 years, that with the use of data, people will become substantially more proactive. Here comes the imagine if. If you are the patient, imagine if through risk mitigation and predictive modeling, that your disease, let's say you're unfortunate enough to be diagnosed with a cancer, and you look at the survival rates of these stage 3 and 4, these late stage cancers are often very poor. But if you look at the opportunity to pick up and identify cancers at stage 1 or 2, then the survival is substantially better, often inverse to what it is in stage 3 and 4. But the problem is, many of the times we don't have the data, we don't have the system, we don't have the ability to proactively find those patients. One project that I'm working on says, well, if you could create a data flow that says all patients' medical records went from birth till now, and then let's say, that I got a disease and I was 70 years of age, and you could go into the system and find all of the people that were my digital twins, same age, same ethnicity, same medical history, all of those things, and go back and to say, well, that's interesting. A large number of these people all had this same childhood disease or this same environment where they were living in. That is the type of thing that we should be aspiring to become really curious about. Can we go from treating to curing or preventing? That is the number one piece of it. What does it mean for people like those people that are developing drugs to treat those patients? Well, if you have the ability to be able to more efficiently use data, particularly, a vast, trillions of data points, and I'm not exaggerating that. It means that you can start to uncover some of the things that will enable you to tailor that therapy more effectively to the patient. Remember the precision medicine definition. The other thing that within hospital systems and the hospital delivery of care, and one of the biggest concerns that I deal with my clientele is, what about the community hospitals? What about those people that don't enjoy the benefits of being close to a large city, being attached to very effective clinical trials, that don't have these large IT systems? How do you deal with that? Well, that's where the majority of the patients are. So being able to remove the tyranny of distance, to be able to improve the fluidity of data flow, to be able to enable workflows to be more efficient, including adding or subtracting things that are high or low value, is going to be critical. But the other thing that I think is really, or two things. The other thing is from a regulatory point of view. Was reading an article the other day where it was saying the cheapest drug today that's coming to the precision medicine space is about $4 billion worth of development cost. And let's say, this is a data point, the net profit is about 25 to 30%. It means that that pharma company needs to sell about $13 billion worth of that drug before it even breaks even. Well, the problem is right now it's taking so long to develop that you now have 7 to 10 years of patent left before you get what they call the patent cliff. So what it means is that many of these organizations never get to a point where they break even. Now, a lot of people say, well, drugs are so expensive. Yes, that's right, because the cost to recoup, but also the way that we fund it in the United States in terms of the markups and the other people that actually part of the selling price, means that there's a real challenge that the future, next 5 or 10 years, whether it would be drugs, whether it be devices, whether it would be new surgical procedures, whether it would be the way that cost effective delivery of care is managed by geography and by patient type, is incredibly exciting. And I think that, for anyone thinking about, things like AI, it's about understanding your current process, workflows, protocols, disease management. And don't be frightened by the term AI. Be more focused in on saying, imagine if I had, you know, 10, 100, 1,000 times more data points that I could make decisions out, that I wouldn't have to try and nut it out myself with my own gray matter, that could actually prompt me. What would that mean? And I think these are the things that people should be focused in terms of delivering better patient outcomes into the future.
Yeah, you bring up so many good points there too, and I think you really highlight that AI is a tool, right? It doesn't displace the human thought, but it can definitely be guided significantly to help us go faster. You touched upon briefly uh, the digital twin concept.
Mm.
And I was just wondering if you could share your thoughts too, of especially in the vision you just laid out there, how important creating that digital twin can be to getting access to these data.
There's a couple of bits to that, and I wrote a program a couple of years ago called Project Renovo that says if you had a population whose data you could get from birth to death, and to be able to, you think of they talk about multi-omics. Omics is, just the field of observation. Could be genomics, the gene. It could be, it could be episomics, what you're exposed to. It could be proteomics, so the proteins in your body. If you could then go into that system and you could identify a disease state and you could apply all of those different biomarker or measures to that patient, and then go into the system. And for those people in the audience that aren't familiar with the term digital twin, or at least how we're referring to it in this conversation, is to say, if Jonathan Meek has disease A, and looking at his age and his ethnicity, all these other things, all these other factors, is there someone out there who've got exactly the same pieces of data? Because if you could find all of those people, because all of the data that I was talking about with Project Renovo was laid out, then you could then go into those people and you could say, well, we've found the digital twin of that patient. Now let's go and find, was there any commonalities in their life 10 years ago, 20 years ago, 30 years ago? Because if you did that, you're now turning the healthcare paradigm from treating to preventing. And when you have a look at, if you look at a patient that has a pancreatic cancer, for instance, their survival 5 years is in single digits. So it's tragic. But what if you could find a way that you could prevent it? These are the things that should be critical to us. Another quick other point. I talk about digital twins in terms of patients. But I'd also say that there is an operational digital twin, which we shouldn't forget about as either. Because if you could say that if an academic center produces a healthcare delivery that is gold standard, then why couldn't that same process be picked up and integrated into someone else's to be able to improve that? Why couldn't they then compare the two to be able to gather greater insights and accelerate the follow up to improve it and to advance it and to evolve the outcomes of care? So I think that these digital twin concepts, although often, once again, may be overused, pretty exciting when the imagine if question comes in, and the imagine if says, what can we do to improve the delivery of care? How can we turn the delivery of care into prevention rather than cure?
I think that's yeah, it's such a wonderful explanation of it, and it addresses the point that you made, especially with some of the, for lack of a better term, healthcare deserts, right? That where patients may not have as much access, but now because of some of these insights, they can receive better treatments by being more preventative.
John, just to comment on that, one of the things
Mhm.
that's really worried me, one of those things you think about a lot.
Mhm.
And in the oncologic world, there was so many situations where patients would rely on being enrolled in these trials where they can get therapies that may be in development early, not fully available in their standard of care. But in the community hospitals, what we found is many of them weren't even getting the type of diagnostics that would question, are you available? Are you appropriate to enroll? There's no good reason why that shouldn't happen. And a lot of that could, and this is actually what you could say was sort of an incremental innovation question.
Right.
Because if it simply said the hospital that is running that test that's more effectively enrolling that patient can share that with the hospitals that aren't, then everyone benefits. Sometimes small changes to workflow with the use of data can have just important and fascinating results in terms of the outcomes of the quality of life and care of a patient with a particular disease.
No, absolutely, and and that was exactly the clarification I was hoping you provide because I think it's like you said, sometimes little changes can have huge impacts throughout the chain. I was wondering if you could also touch upon if we have that digital twin aspect. What are the implications then? Also having that data set for the pharma companies as you look at that.
One of the questions that I get the most is about patient security, data integrity. And I think one of the things that we tend to forget about, and that is in the days where patients' handwritten records were digitized and, Jonathan Meek, they might have been put into a field in the thing was an address, not a name. And then at some stage in the future, when all the patients' names get what they call tokenized. So it turns Jonathan Meek into 1, 2, 3, 4, 5, for instance, and now forever on that Jonathan, no one knows who Jonathan is. He or her is a number. But I think that a lot of the times these hospital systems were very terrified about data integrity. And I think that as we evolve, AI, and we've talked about AI doing better data analytics to uncover the good of delivery of care, development of new approaches, it also can work against the bad. It can also, AI can also go into a system and to identify when that data doesn't look right and to be able to triage it out. So I think that in the future, one of the concerns that people have is, well, will my data go in the hands of someone who's going to make money from it? And I would turn it around the other way to be able to say, if your data treated appropriately, let me reinforce that it's no longer Jonathan Meek, John Holcomb. It's 1, 2, 3, 4, 5. If that could go in to improving the lives of people that in your community, in your family, brothers, sisters, mothers, fathers, wouldn't that be a benefit to you? Because part of the reasons why some of the drug developments fail is that there isn't enough data that can help you validate that the benefit that we think will come to you actually is coming to you. And, this may be a comment that is not often popular, but I think that if all of patients' data could be rolled up, making the assumption that it's safe and it's anonymous, and we could understand the way that the human biology evolves to a point that we can see into the future because we can start to predict things, the impact that we'll have on some of these diseases that kills millions of people is really quite interesting. The biggest step we need to make is the courage that we have that says, what does it look like? Where do we put it? And how do we make access to it that people can research? And, this is evolving at a rapid rate. And I think it's easy to look at a glass half empty and to be able to think of the risk piece of it. But the level of advanced analytics now is working to be able to make sure that it is significantly safer and getting to that point where the benefit vastly outweighs the negative.
Yeah, I think I completely agree with you on that, and that's where what you shared to me really connects some of those dots, right, of how AI can really support this whole, y you know, uh, precision medicine approach, because now you can design precision medicine based on the data that becomes available, assuming we can knock down some of those barriers. No, I think this is just such a fascinating area. Hopefully, I think folks can see like the challenges though that we have to deal with regulation, patient confidentiality. Truly exciting, right? The possibility it can be within sight.
John, let me give you another anecdote that happened in the last few months. And I was sitting with a research group, and the research group was looking at the area of sepsis. And for the audience, sepsis, people think of sepsis being an infection, but a lot of the times when patients die, there's no longer infection. The body's pro inflammatory and anti inflammatory natural influences have basically shut the body down. And then you go into organ failure and the patient dies. And many of the physicians get really concerned that often it's a too little, too late situation because trying to define very quickly or very accurately that that patient is at risk of sepsis and doing something about it is much harder than you would imagine. So we were sitting down with this research group and we had a series of patient notes anonymized, part of the research set. And they said, if we asked you a question using natural language, so just typing it in normal language, can it use what they call large language modeling to answer the question? And one of these thought leaders said, ask it, what are the biomarkers that started to raise early enough that would enable me to make a decision to improve the delivery of care? And it went into the system, it went through these notes, and it came out within 10 seconds. And this person said, did you know something? If I had have done that before, that patient would have been in a critical situation or even dead before I even had the ability to be able to sum this stuff up, because no two patients are the same. It's an example of the type of things that not only the quality of the information that you can generate, but the specificity to the decision that you are trying to solve or problem you're trying to solve and the decision you're trying to make, how quickly that can come around. Just something that was front of mind.
No, I truly love that example because I think that really hits home in terms of how fast things are improving in terms of the ability to identify, right? And the proper use of AI tools.
End of the day, it's just coming back to doing the same things substantially better. And you get
Yeah.
to the point where it tips the way that you're going from reactive to proactive. The more we can get proactive in healthcare, the more people are going to have their lives improved.
No, I love that. And Jonathan, this has been such a wonderful conversation today. One thing I'd like to do is pause and just ask if there's anything else that you would really like to either share or summarize from today's discussion.
Innovation and leadership are the two key things here, John. If people are listening to this and they're thinking about what can I do, what can we do, what can my organization do around innovation? The question is, understanding the problem to solve and the problem behind the problem. First thing. Second thing, understand, is this a what situation, a how situation, or a why situation? And it will understand, sure, the level of investment, time, work needs to be done will be different, but so will the outcomes. So just be clear about that. And the last thing, leadership is about being able to have people rally around a common goal. The common goal in healthcare can go across a vast landscape of stakeholders. Understanding those stakeholders, engaging with those stakeholders, listening to those stakeholders to uncover the problem, and the problem behind the problem is a critical one. Innovation in healthcare is just a fundamental need right now. And so, those people that are wanting to lead it, thank you very much. I appreciate it and I'm grateful.
No, thank you so much, Jonathan. I think you highlight, I actually had spoke with somebody just the other day and they mentioned innovation's a team sport. And I think your last comment there is just perfect highlights of that, right? It takes a group of people making sure that you're going with the stakeholders and really being clear on what problem is it we're trying to solve. So appreciative for the work and your thought leadership in the field. I'm looking forward to many more conversations with you, and thank you for being here today.
Thanks for having me, John. I'm grateful for it and I love this conversation.
Excellent. Thank you so much.